Good morning, everyone. I'm Megha Rao. I'm a Global Health Research Fellow here at the Center for Health Economics. Unfortunately, Christmas was not able to join us, but we have Sakshi Mohan as well on the panel here. I'll be presenting the work that we have co-produced with the Makerere School of Public Health. And I'm going to now jump into the presentation. Briefly, just to set up the policy motivation for this work. In Uganda, obviously, there have been considerable improvements in health outcomes. However, in terms of looking at expanding healthcare provision, one of the challenges that continues to remain is severe shortage of skilled workforce. And also large rural-urban maldistribution, that is concentration of skilled workforce in urban areas rather than rural, where 74% of the population lives. Combined with that is obviously the high preventable disease burden and fiscal constraints, along with frequent epidemics, as well as low UHC coverage. So the government was obviously looking at ways and to expand national healthcare provision through a more comprehensive workforce strategy. And the policy response for this was obviously launched in February 2023 through a national community health strategy that looks at strengthening primary healthcare through scaling up of community-based care and strengthening linkage to the wider formal healthcare system. But there was recognition of the fact that community care in Uganda is quite fragmented, and there is a need for a more structured, integrated community health platform that links to the formal healthcare system. However, evidence on this is quite limited, and that led to this particular piece of work. The idea was to focus research on evaluating the system-wide impact and the value for money evidence on integrating community-based providers within the public health system as a formal delivery platform to guide national planning and investment. What was seen through earlier literature reviews and the work that Makerere had done was that there were two key community-based providers that showed potential for integration within the wider system, and that was the government-recognized village health teams, which are also known as your community health worker cadre in Uganda, as well as the medicine retailers that comprises of retail pharmacies as well as drug shops. Both play a vital role in terms of providing care where there is limited public provision. However, limited evidence is available on what their broader value looks like across multiple disease areas, with medicine retailers remaining largely absent from national health planning. So our focus was to evaluate what the added value of integrating these providers, VHTs and medicine retailers would look like for delivering Uganda's national essential healthcare package. We focus on the UN EHCP because it defines the core services that the public health system must deliver in Uganda, so it gives us an opportunity to assess what their system-wide national level impact looks like. Alongside the facility-based system. The method we use is a linear constraint optimization model. So we compare two strategies, which is a baseline strategy where we see what is the maximum health achievable with a facility-based system only versus an integration strategy where we're looking at the maximum health achievable with the inclusion of community-based providers, and comparing the two obviously gives us how much community-based providers measurably improve health. Very briefly on how we use constraint optimization model without going into the technicalities of it. It essentially helps us define a set of or a portfolio of healthcare interventions that maximizes population health while taking into account the multiple short-term binding constraints that the Ugandan healthcare system faces. So we start with obviously determining the input data, which is looking at what list of interventions could potentially be included in the package, gathering data on health effects as well as costs per case, as well as the required resources per case. And the two sort of resource constraints we focus on is obviously the human resource time, which includes both facility-based cadres as well as community-based providers, as well as the drugs and consumables cost. We then define the constraints, which is the total available drugs and consumables budget and the HR time, and then obviously move on to also account for platform-specific data, which is data specific to community-based providers. So how does their involvement adjust staff time or reduces the facility-based staff time, recognize that not all of these services can be provided by them. So putting restrictions on that, as well as using or they can obviously only serve a certain percentage of cases to reflect basically the realistic care seeking patterns within the population. The model then solves for, well, what's the optimal allocation of cases across these platforms, whether it should be only facilities or jointly with community-based providers, and what's the list of services that can be included in the package while maximizing population health, but also while staying within the defined system constraints. So the policy relevant outputs are, well, what should be delivered and what should be optimal coverage, how should it be delivered, what is the expected health impact, and how will it affect resource use within the healthcare system. So these are basically the different types of strategies that we have evaluated against the baseline. So the baseline is only facility-based care. We then introduce the VHTs, which is the standalone VHT integration. VHTs contribute through task sharing, so they reduce the time required by the facility staff, but doesn't completely eliminate it. We then only introduce medicine retailers, which is the standalone medicine retailer integration. That in that case, medicine retailers basically fully substitute for facility pharmacists, so they only handle drug dispensing. And joint integration is obviously introducing both of them or including them together. We also have a scenario where we do not limit the percentage of cases that can be supported by the community-based providers to see what happens if you address these different demand supply constraints that restrict care seeking from them. And then obviously also include a markup scenario for medicine retailer incentive. So we assume that government reimburses them 25% above the drug cost per case. So all of these scenarios are then compared to the baseline to understand added value. This is just a snapshot of the data set. We have 194 interventions across 12 disease areas, and all of this data has been validated by in-country experts and official documentation. Jumping into the results, we start with the baseline strategy. The graph shows you the percentage of resources that are required for each of these to obviously deliver each of these strategies. So with the baseline, sorry, I can't see the, yeah. So in this case, we see that there are 38 interventions in the baseline strategy with 111 million net DALYs averted. The key bottlenecks, which you can see are those resources which are being used to 100%. So they are pharmacists, nutritionists, and mental health staff. And obviously the other cadres and the drug budget remains underutilized. We then bring in VHTs only. And then we see that the package expands by 6 interventions, and the additional net DALYs averted by them is about 2.9 million. We see largest gains in areas like RMNCH, HIV, STIs, and malaria. And this also shows that several interventions basically shift from facility-only management to shared management with the VHTs. There's obviously higher utilization of the consumables budget and a marginally lower use of HR, facility-based HR time. The third scenario is obviously introducing only the medicine retailers. We see that the package, it's a broader package than VHTs because it's about 60 interventions, which is 22 more than the baseline. And this is because they obviously address the public pharmacist constraint, but the overall health gains that are generated by them are relatively lower than VHTs, which is about 1.8 million, because of the differences in the scope of their role compared to that of VHTs. They have been introduced in a very restrictive manner because obviously there are regulatory and safety concerns regarding their involvement from a clinical perspective. Greatest gains are seen in malaria, integrated management of childhood illnesses, HIV, STIs, nutrition, and RMNCH. Medicine retailers are being used up to 5%, and resource use has increased across the board. We then look at joint integration, and this probably is the most that is the one that yields highest gains because it leverages both types of providers. So it increases the package by 25 interventions and generates added value of 4.7 million net tallies averted. We still see that the capacity of these providers remains underutilized. And that's points towards the fact that the current policies, which we have obviously incorporated for limits utilization. So it's role limits, gates limits, feasibility, and obviously reliance on other facility-based providers. And even the consumables budget is now completely used. We then move on to a scenario where we remove the constraint on the percentage of cases that these providers can support, and that boosts impact considerably. We can see across the board that there is much higher health added value, additional net tallies averted, even in terms of resource use that has increased, and even doctors reach full capacity. In this case, we see a flip. Medicine retailers actually outperform VHTs in terms of health gains, and utilization also rises for both of these providers. The package, obviously, for medicine, where medicine retailers are involved, which is the last two columns, are smaller than before. But that's because now medicine retailers are able to focus more on high impact interventions fully, rather than restricting their use, which was happening before, due to which their contribution was getting diluted across other low impact intervention. So this points to the fact that obviously role expansion should be prioritized, but that must also be matched with safeguards like incentivization, regulation, and obviously proper training and supervision. This presents the results for the consumables markup. And what we do see is that when there are case limits, markups, the effect of them markups are quite minimal, but obviously it does show that there's a reduced reliance on medicine retailers, but that's because the consumables budget was already constrained. And even without the case limits, we see that not only is there reduced reliance, but also decline in overall health gains. So all of this points to the fact that, well, for medicine retailers to contribute more cost effectively, markups need to be regulated and more governance mechanism needs to be put in place to see how that can be done. We also calculate what should be the maximum cost effectiveness investment towards each of these providers through our analysis. So this is the maximum amount that Uganda can invest per VHT and medicine retailer to deliver the optimal package in the current year while remaining cost effective. And these thresholds can help inform system gaps, underinvestment, as well as resource allocation. So for VHTs, it's about $423, and for medicine retailers, about $19,800. And we were also able to estimate the average cost effectiveness of VHTs, given that they're obviously not a constraint in the model. So this determines how much, what's the average amount that can be spent on the salaries per health worker type to avert one net tally. Comparable estimates could not be developed for medicine retailers because they are not provided a salary. So we just did these for the community health workers or the VHTs, and they show, despite conservative assumptions, excellent value for money, and they're pretty cost effective at $42 per net tally averted. And when you remove these case limits, actually their cost effectiveness doubles. We obviously also look at some key considerations for the future. All of these outputs are dependent on the model and the model accuracy, and that can be improved by improving or updating the underlying database, the cost effectiveness data, as well as resource use data. We currently treat the interventions as independent, so which means that the costs and effects of one doesn't depend on the others. But that's not usually the case. We obviously manually code for it, but a more comprehensive evidence base is required to account for complementarities and interactions. We assume costs and effects scale linearly, but obviously to capture economies of scale, nonlinear production functions need to be accounted for. In such cases that we're trying to build for community health systems, we need to capture real world transition costs, as well as account for differences in treatment outcomes when you're allocating tasks between different providers with different levels of training. We're looking only at efficiency right now or health maximization, but obviously equity and financial risk protection can also play a huge part, and are social objectives that must be looked at and included in the future. And We also should explore in future research demand side, how these providers can relax demand side constraints on healthcare utilization.
Thanks very much. Hi everyone, and thanks for the opportunity to present today. I'm going to be presenting a sort of very high level overview to give a taste of some work we did looking at, as Edward mentioned, health system financing, performance and resilience in African small and island states. Yeah, so just to plug up front, this work has been published in two complementary papers, one in health policy and the second in social science and medicine health systems. And the two papers are sort of very much scoping in nature, and they basically try to synthesize the existing literature on health systems in small and island states and to lay the ground for future work diving deeper into some of the key issues in these contexts. So the first paper sort of looks at health financing and system features in this group of countries as they try to pursue universal health coverage. And then the second asks what I guess could be a sort of deceptively simple question, which is that if these countries are highly exposed to shocks, do they respond to this by building health system resilience? And I'll go on a bit more into what I mean by that later. So I guess the starting point is to ask why does this group matter? So this group of small and island states. From an analytical perspective, the hypothesis that state size and location can have sort of significant impacts on economic development and policy considerations has been around for a while. So Simon Kuznets in the 1960s introduced this idea of penalties of smallness, and Paul Collier has highlighted what he called the small country problem as specifically contributing to development challenges in Africa. And then these ideas were sort of brought even more to the fore later on with economic geography, which brought more attention to the issues associated to country size and location, primarily focusing on economic growth, trade, and development. So just to be a bit more specific about what these problems are and have been hypothesized as, small and island states are characterized by having small domestic markets, which increases the importance and reliance on international trade. But at the same time, these countries, they struggle to benefit from economies of scale, resulting in high production costs, which can reduce trade competitiveness, and sometimes high transaction costs as well, stemming from remote geographies. And basically, this can result in a very heavy reliance on the public sector, which is often a lot larger as a proportion of GDP than in larger countries, or on a very small number of key strategic sectors. And so the economic health of these very small number of sectors really determines the sort of overall economic health of the countries. And basically, partly because of these sort of features and also climate factors, small and island states are also very characterized and recognized as being disproportionately exposed to economic, environmental, and climate shocks, which can have countrywide and system-wide impacts. And so taken together, basically all these challenges can impede economic development. And because of the recognition of these shared challenges, a number of political sort of special interest groups have emerged around small and island states, starting back in the 1990s, to essentially heighten their voices on the global stage, and make sure that they're sort of heard when it comes to policy dialogues. even despite this, the relative small size of these countries often still leads to them being overlooked at regional level. So, in this work that we did, there's been many definitions of small and island states. The World Bank, the UN, IMF all has different kind of definitions and groupings. In this work, we focus on 14 small and island states in Africa, which all have a population of less than 2 million people. And so this represents, it's about 32 million people altogether, which is only about 2% of the total population of Africa. And that's despite these 14 countries making up 26% of the countries on the continent. So, despite this kind of long-standing acknowledgement that state size and location can play a role in a country's economic development and the distinct challenges that it faces, there's been really relatively little systematic examination as to whether state size could impact the performance of health systems and healthcare systems. So we sought to kind of plug that gap. And the first paper, the first approach we took was to essentially benchmark how African small and island states look on or in terms of health system functionality and selected health outcomes and performance metrics compared to their larger peers, so a comparative analysis. And then we, in the second paper, basically separate health system performance from resilience. So at a very high level, performance can be thought of as how well a system is delivering under normal conditions, so sort of coverage, quality, and health outcomes. And then resilience is a term that's sort of growing in popularity, but is still quite hard to define. But very broadly, it is sort of about preparing for and responding to shocks when they occur without disrupting normal operations and normal healthcare service provision too much. And so, just to kind of jump ahead a bit, just because a country's health system is performing well doesn't necessarily mean that it has appropriately developed health system resilience to sort of guard this progress that it's made. We saw this sort of globally with countries with the COVID shocks. A lot of health systems that we thought were high performers didn't respond particularly well to this event. And then within these two kind of questions or topics, there's a number of sub-questions. Are the health systems of African small and island states distinct from their larger peers? How can we best track these differences? And are standard performance metrics sort of appropriate given the structural issues that these countries face? So, as I mentioned, for the initial sort of comparative analysis, we structured the work around the WHO health system building blocks. But here, I'll just use three groupings of health financing, health system inputs, and health outcomes to present the sort of findings. So starting with health financing, health financing is influenced by all countries, in all countries, by the broader economic health of that country. And so we started by quite high level by looking at the sort of overall economic picture of the countries of these 14 small and island states compared to their larger neighbors. So we found that the average GDP per capita of the 14 African small and island states is over twice as large on average than its larger peers. So about 283% that of the larger countries on the continent. This average drops a little bit when you adjust for purchasing power parity, and that sort of reflects the higher costs of production and transport costs, but this doesn't offset the fact that these countries are on average more developed. However, despite this sort of higher level of development over the last 10 years between 2010 and 2021, the economic growth rates of these country groupings have been relatively similar. However, we confirm that there is a much higher volatility in this economic growth rate, this annual economic growth rate among the 14 small and island states. So that's sort of a confirmation that they can be potentially subject to economic shocks or other shocks. Might be dependent on certain sectors, which might be cyclical or have events that can impact them. Looking specifically at health financing, then the average total health expenditure per capita among the 14 small and island states is about $245 US dollars compared to 86 US dollars in the larger peer countries. And this is partly due to that higher developmental status that we just spoke about. But it's also due to a greater prioritization in general government spending on health among these countries. And as we'll see a bit later, the 14 African small and island states and the non-small and island states have similar life expectancies. So this greater prioritization might be due to a recognition of the higher importance of developing human capital in these countries, of which health is an obvious input into human capital, because many of these countries have sort of lack natural resources, and so they rely very heavily on their human capital for development. And one aspect to highlight, which is a constant issue and sort of runs throughout this work, is that the publicly available data for the African small and island states is much less readily available than for its larger neighbors. So it's much less well covered by sort of standard global surveys such as the DHS. And then even when there is public, internationally comparable data, you realize that a lot of the figures are much more heavily reliant on extrapolation and interpolation. So data issues and differences in data for drawing these conclusions are distinct as well, and something that needs to be looked at further. So then moving on to health system inputs, again, African small and island states seem to perform relatively well despite the potential hypothesized challenges. Medical brain drain has been highlighted as an issue in general for small and island states globally. And due to the sort of low absolute numbers of health workers in these countries, a small number leaving emigrating to go abroad can have population-wide impacts, particularly when you get to sort of more specialist levels of health workers. However, African small and island states have higher numbers of doctors and nurses and community healthcare workers per capita. Similarly, in terms of health infrastructure, there's a greater number of hospitals and hospital beds per population. So they seem to be performing well on sort of key health system inputs. Relatively. So this isn't to say that they're performing in absolute terms very well. I think the kind of takeaway for here is that Africa as a whole is still has this ongoing shortage of healthcare workers and health infrastructure, and the African small and island states are just performing relatively better. All of these numbers, these average figures, are far below the sort of WHO recommended numbers. So that's not to say that they've achieved what we would want them to. They're just sort of slightly further ahead than their larger peers. So on health outcomes, there's been a number of kind of hypothesized characteristics which have policy importance among this country grouping. So due to their small size and often dense population, small and island states can be significantly impacted by infectious disease outbreaks. There are examples of disease outbreaks impacting over 50% of countries' populations, such as Mauritius or Comoros with the chikungunya virus. And of course, that can very quickly overwhelm a country's health system. HIV/AIDS is another example where small and island states can be kind of systemically affected. So three African small and island states have over 20% of their populations living with HIV. There's only one larger state in Africa, I think Zimbabwe, with greater than 20%. And so if that's the case where you have 20% of your population suffering from a single illness, that very quickly sort of becomes the central focus and of the health system, which gears itself very heavily towards dealing with this at the expense of potentially other illnesses. However, despite these sort of challenges, small and island states can also benefit from structural advantages in disease elimination, and this has been seen from the fact that only 3 countries in Africa have achieved malaria elimination, all of them small and island states, Lesotho, Mauritius, and Seychelles. And then the countries which are close to elimination, 5 out of 6 of them are small and island states as well. So basically, this comes with challenges and potential upsides and benefits if you can use policy effectively. Despite these sort of differences in structural factors and disease profiles, life expectancy is similar between these two categorizations. Small and island states perform slightly better on classic sort of poverty-related health metrics, such as under 5 mortality and maternal mortality rates. But there's a lot of heterogeneity there, and this is obviously ever present when making this kind of cross-country analysis. So you have some small and island states where they are the best performers on the continent in terms of these illnesses, and some such as Guinea-Bissau and Lesotho, which are among the worst. So, you know, whenever you're making these kind of country groupings, you have to be aware that there's not a one-size-fits-all. These are different countries with different distinct issues as well as some similarities. So recently, a lot more focus has been given to health system vulnerabilities and exposure to shocks. As mentioned, COVID sort of centered attention on some of these issues. And so after this sort of overall health system performance and outcomes stock take, we examined the difference in the level of exposure these countries have to systemic risks. And we did this by using a multi-dimensional index developed to assess country-level exposure to economic, environmental, and other structural risks, comparing the small and island states to the other larger population countries in Africa. And essentially what we found is that at every level of development, you can very clearly see that the 14 African small and island states are more exposed than their larger peers. So again, this chimes with what the wider economic and environmental literature tells us. But then the question becomes, do these countries have a level of health system resilience that's commensurate with this, with their level of sort of risk exposure? And it's important to sort of clarify that just because a country has better overall levels of development and better health system performance metrics doesn't mean that they have higher health system resilience. It may be the case that if these countries were sort of less exposed to and suffered from shocks, they would have even better development in outcomes and greater population health levels. So we don't really know the counterfactual of where their level of where their level of risk exposure is lower than it is. So just having better outcomes doesn't mean that you have better health system resilience. So we searched the literature for all of the available measures of health system resilience, and this is still very much an evolving area of research, and there's methodological challenges with measuring resilience. And what we found basically was that existing measures almost exclusively focused on preparedness. So preparedness is obviously an aspect of resilience, but not not all-encompassing. Resilience also is a dynamic concept and sort of uh, captures how you bounce back from shocks as well. So preparedness is just one way of measuring this. However, with these measures and indices that we did find, we found that small and island states have worse average scores than their larger peers who are less exposed to systemic risks across all of the identified metrics measuring health system resilience and preparedness that we found. So you can see in the sort of bottom right-hand corner, the bottom right-hand quadrant, that there are a number of small and island states in Africa who are categorized as having high health system performance, but have lower than expected health system resilience. So despite this strong performance, there appears to be a kind of essentially a policy failure in not building resilience to guard against the level of risk that these countries are faced with. So that was a kind of key finding that we had, and really hits home the message that performance does not equal resilience, and that particularly for countries facing in this context, just looking at performance might do an injustice into kind of how they're actually doing as health systems. So there are a number of takeaways from this scoping work. Firstly, the health systems of African small and island states can be viewed as performing relatively well to their larger peers, with higher total health expenditure per capita and higher prioritization of health spending, and relatedly lower donor dependence. And this suggests either that the sort of hypothesized structural impediments are less severe than feared, particularly from a health system perspective, or that good policy has effectively mitigated some of the challenges, some of the health sector challenges that these structural factors might impose. The downside is, as mentioned, that these countries remain very exposed to shocks relatively, but this exposure has not led to the building of health system resilience to what might be considered an appropriate level. And that's caveated by saying, these are only the measures of resilience that we have available to us. So this is an area of research where more work needs to be done. There remain a number of sort of hard policy problems to solve in these settings, such as how to reduce dependence on imported medicines. And again, COVID sort of hit home that when you have global supply chains, and there was a surge of demand for medicines. There was sort of countries were prioritized and other countries deprioritized, and this became a big political and health issue in terms of access to COVID vaccines, and the same is true across the board for all imported medicines. And then another issue would be the dependence on sort of needing to seek specialist care abroad. A number of these countries spend a huge proportion of their budget on what medical tourism, essentially, where you fly people out of the country to receive cancer treatments or specialist care, and there's obviously a huge opportunity cost when you spend a lot of your budget on doing so. It remains an open question as to whether the improved performance is solely down to this average higher level of development, and if it is the case, then this would suggest that as larger African countries continue to develop, they'll be able to attain better outcomes for the same level of spending as these small and island states have now. So, is what might look like a good thing now could turn around, and actually we find out that no, these kind of structural impediments facing these countries are causing problems and require addressing. And then lastly, a sort of emerging area of work is how to measure health system resilience generally for comparative analysis. I've touched on this, but because of its importance to small and island states, I think they're well placed to sort of try and take a lead on this and work with researchers to come up with better ways of measuring health system resilience, which can provide policy insights for the broader global health community. Um, and then, yeah, just to come back to the point about the sort of data issues, I think more work needs to be done on building data and uh, understanding of how these distinct characteristics facing some of these countries impact health systems specifically, um, without sort of building this evidence basis and the accompanying policy insights. These countries, which, as mentioned, are 32 million people on aggregated, risk sort of being overlooked by their faster, larger populated growing neighbors in trying to achieve universal healthcare coverage. So I think I'll leave it there. Just to reiterate that there's a lot more detail in the papers, so I'd encourage anyone interested to seek them out, and you'll get more sort of insights into each of those broad topic headings than here. And of course, happy for anyone to reach out via email with any questions on this work. So thank you very much.